Good morning, everyone. I just got the wonderful news that I'm the lucky first presenter of the day. So hopefully this will be an icebreaker for everyone. Okay, just a brief overview, the obvious reasons why we decided to implement the AMS program. We have absolutely no choice in South Africa to do so, but due to an increase in microorganism resistance, responsible antimicrobial use is a necessity. There's very slow or no development of new antimicrobials, so we have to use our available ones as responsibly as we can. And the increase in last resort antimicrobial use colistin. So I'm just going to run you through a brief overview of our AMS journey over the past couple of years. In 2010, a list of important antimicrobial stewardship interventions were identified that were compiled into an AMS bundle, which would then continually be monitored even up till today. These bundle elements include requesting of microbiology results, appropriate daily dose of antimicrobials, limiting of the number of antimicrobials on a prescription, and in that way limiting antimicrobial spectrum duplication, tailoring of antimicrobial therapy to microbiology results, appropriate duration of therapy of surgical prophylaxis, IV hang time, and assessing the opportunity to step down from IV to oral therapy. So our aim of monitoring these bundle elements are really to improve AMS bundle compliance, to increase the number of patients assessed for AMS bundle compliance, to reduce the rate of pathogen resistance development, and to reduce colistin utilization. That was our initial aim. In 2011, 9 pilot hospitals were identified, and the AMS program was purely pharmacist-driven. After implementing these and continually monitoring these AMS bundle elements, a positive response was received from the multidisciplinary team as well as hospital management. And in 2012, there was a rollout to all Life Healthcare hospitals. Pharmacist involvement grew, and the program maintained to be pharmacy-driven. We then realized that AMS would be more of a success if it's a multidisciplinary approach, and we can in fact involve nursing staff into monitoring AMS bundle elements relevant to their scope of practice. This was piloted in 4 hospitals and was a complete success, and then nursing involvement also grew in our AMS program. Throughout the program, we also aligned our AMS committee formation to the CDC recommendations and the World Health Organization recommendation, as well as our own National Department of Health, to identify AMS champion doctors to also be involved. And currently, in the majority of our hospitals, we do have AMS doctor champions taking leadership of AMS committees together with our pharmacists. In 2013, we then aimed to evaluate as many antimicrobial prescriptions as possible, but at least all ICU patients needed to be assessed. This was a success, and the program rolled out to all units in the hospitals. In 2014, Life Healthcare invested in ICNet, a microbiology monitoring program where real-time lab results are fed through to this program and are available for view for our pharmacists and our infection prevention nurses. The program was piloted during this year, and in 2015, pharmacists and infection prevention nurses gained access to the program and could actively monitor microorganisms in the hospitals as well as their resistance patterns to tailor appropriate antimicrobial use to the resistance patterns. In 2016, we developed the AMS dashboard, which would include information from your AMS bundle compliance results, your microorganism data as well as your antimicrobial utilization data. Those are, I'll show you the dashboard just now, but those are all available on one page at a glance, and you can immediately review whether antimicrobial use in that specific hospital is appropriate to the microorganisms cultured in that hospital. Here is just to show you how our AMS program grew. We recognize that when continually suggesting interventions, antimicrobial prescribing would in fact become more responsible. The interventions would decrease over time, and the number of patients assessed would eventually exceed the intervention suggested. So although we are aware that our pharmacists assess all antimicrobials prescribed, we are here reporting on what is captured on our own system and that we have electronic data available for. But the program clearly grew, and in August 2016 reached the highest numbers throughout the past couple of years. Colistin utilization we actively monitor, and we found that in 2012 the utilization was a bit out of control. I'm sure it's not something that was unique to our group, but we worked actively, and although at some points during this past year there were peaks in the utilization, in August that it reached the lowest point it's ever reached over the past few years. The AMS dashboard, just to give you a quick glance of what can be viewed from the dashboard, and there are many more things on the dashboard, but it's color-coded, showing that, for example, your green bundle compliance show that you are reaching your targets. Your acceptance rate of your interventions is also important. If it goes below 80%, we would generally intervene and ask why the doctors are resistant to intervention suggested. On this dashboard, surgical prophylaxis, and this is an example from one hospital, appear in orange, which means in that particular hospital that might be a focus area for them currently. It just shows you which areas to focus on. It also shows your top significant organisms, which is your escape organisms, and we've included your Candida species, your Clostridium, and your carbapenemase producers as well. Colistin usage is our current extreme drug that we are monitoring, and we're monitoring utilization as well to see whether it's appropriate to the organisms cultured in the hospital. So the journey continues. Just to wrap up, documents and electronic tools were continually developed and tailored to our stewardship program to make stewardship as easy as possible for our pharmacists and our multidisciplinary team. Most important learning point is a multidisciplinary approach is the key to a successful antimicrobial stewardship program. Thank you.